Welcome to our podcast, The Prescription on Earshot Media. I am your host, Dr. Karan Thakur. We carry forward our discussion with Dr. Achal Bhagat, Senior Consultant Psychiatry at Indraprastha Apollo Hospitals, in this two-part episode.
Indraprastha Apollo Hospitals presents The Prescription in association with Earshot.in.
Welcome back to the podcast, Dr. Bhagat.
Hi, Karan. How are you?
I'm well. Thank you for joining us back. In our first episode, we looked at anxiety and depression. And in this section, we'll discuss bipolar disorders and schizophrenia. So I'll dive straight in. Dr. Bhagat, what are bipolar disorders, or what is bipolar disorder?
Bipolar disorder is a mood disorder, right? It's largely a disorder of mood where the mood fluctuates episodically. You could either have a mood which is elated or with the behavior being overactive with increased levels of activity, increased levels of confidence, bordering on to being delusional about one's abilities or one's identity. Spending a lot of money, having lack of sleep, increased or decreased appetite. This could be hypomania or manic phase of the mood disorder. Contrary to this, and completely opposite, you could have within the same person at a different time, a low mood with lack of interest, with depressive cognitions like helplessness, hopelessness, and a loss of confidence in oneself, worthlessness, and ideas of self-harm, with again sleep and appetite disturbances. These mood disorders, again, there could be just one kind of episodes that happen, just hypomanic or manic episodes that repeat themselves, or there could be a series of depressive episodes with only one or two hypomanic or manic episodes. Or they could be mixed episodes where two kinds of symptoms come together at the same time. Mood disorders are fairly common and not as common as anxiety or depressive disorders, but or OCD, but they are common enough to say that they are present in about 2% of the population. So 1 to 2% of the population. And people confuse it by using the common parlance, I'm bipolar. For anybody who is impulsive or their mood fluctuates from time to time, or they become too happy. For a person to be diagnosed as bipolar mood disorder, they have to meet a certain criteria, which has been set by WHO and by psychiatrists coming together. And it should not be a label that is thrown around.
Right. And does it develop over time? Do mood disorders develop over time, or is it something that may happen one fine day, let's say?
It is something that presents itself as an episode. You may see it coming over a few weeks, but when it develops, if you've had one episode, then it's likely to come back as another episode.
Right. And are we talking about highs, and the highs being too high and the lows being too low, or is this something different?
So highs and lows are part of the diagnosis, right? So, but if somebody has a high, then they would be classified as having a bipolar mood disorder.
Okay. And what are the warning signs, let's say, to watch out for, either for yourself or for a loved one or a colleague, for mood disorders?
So any sustained change of mood, any sustained periods of time where you have increased levels of activity beyond your usual self, where you have lack of sleep and appetite bundled together, significant amounts of confidence, overspending, feeling that you can do multiple things at the same time, and these come in episodes, right? they're short lasting. They are over and above your usual personality. If you have any of these symptoms coming together as a cluster, you should look out for them. And on the contrary, if you have a low mood in the context of these high moods, because you could have low moods, as we discussed the last time, as a depressive disorder as well. But if you have low mood and lack of interest and depressive cognitions like helplessness, hopelessness, and worthlessness, and ideas of self-harm coming together for periods of more than 2 weeks, you need to seek help.
Right. And the highs also, or the hypomania phase also could be for weeks on end, or is it for days or hours?
Right. So it can present differently. The usual presentation is that there's a sustained change of mood for 2 weeks. But there could be what is called a rapid cycling or an ultra rapid cycling mood disorder. An ultra rapid cycling within the same day, there could be mood changes, or a rapid cycling within the same week, there could be mood changes.
Right, right. So just like we discussed the last time around anxiety and depression, you could have anxious thoughts and which may go away, or you may feel sad and it may not be depression. Similarly, for mood disorders, is it possible that you could be moody or grumpy and not necessarily have a mood disorder?
Right. So again, it's a continuum. The 3 words that that will help people understand it is the amplitude, the duration, and the frequency of the change of mood. If the amplitude of the change, which means there's a change of mood, the degree of change in mood, how much is that, and how significantly different it is from your usual self, that will determine whether it's a disorder or not. The second is the duration that it lasts, and a sustained change of mood for 2 weeks, and then coming back to a different mood would definitely make you wonder about a disorder. And then if it is happening frequently over a period of time, it keeps on coming back. So that will, and then it's causing distress and dysfunction. In the case of hypomanic or manic moods, the dysfunction may not be visible to you because the person may not be in contact with reality, or may be so caught up in their symptoms that they may not be able to understand that they're in a high mood. But the observers, the people who are well-wishers and people who are around them, may see it happen.
Right. And how do we differentiate between depression and bipolar disorder?
So as I said, a depressive disorder is of a sustained change of mood of the depressive kind. A bipolar mood disorder is a sustained change of mood of the kind where there is elation, euphoria, happiness at one end, and low mood at another end.
Right. And which age group or categories do we normally see bipolar disorders in?
Again, it can happen it can start very early, and it can also happen to older people. Younger people get it more often. Sometimes it can be triggered by substance use. Sometimes it can be triggered by circumstances around you. There can be precipitating events, like we discussed last time, that there's a biological predisposition to the mood disorder, and then there could be a precipitating event in your life which could precipitate the event. And once it starts, then it could keep on happening even without a precipitating event.
Right. And how do I address it?
Largely by going to a mental health professional. Here, the first port of call would be visiting a psychiatrist.
Right.
And learning to recognize this as a disorder. That's the most important thing. A lot of people struggle with this, whether this is a disorder or not, whether this is my usual self or not. Work together with your psychiatrist to arrive at the diagnosis. Denying the diagnosis or fighting the diagnosis ultimately delays the disorder, and it can land up people in life-threatening situations as well. I've known people who've lost lakhs and crores of rupees because of overspending during the hypomanic phases. I've known people in the depressive phases harm themselves. Relationships get harmed, children get harmed. There can be increased substance use during this time. There can be all kinds of impact. People might lose jobs during this phase. So this is a major psychiatric disorder. It needs to be taken seriously. And if you see somebody whom you love going through this, or you yourself are going through this, please reach out to a psychiatrist.
And if anybody were to present themselves to you, what is your typical approach? And I know no two cases are the same, but what is the typical approach towards bipolar disorder from professionals?
Right. So the step one is forming an empathetic relationship, understanding from the person's point of view what is happening. Also getting information from whoever they nominate to be the person that we should get information from in their family or friends. Then after having understood them and through this process, performing what is called a mental status examination, coming to a diagnosis together with them, sharing the diagnosis with them, educating them about their disorder, educating them about the pros and cons of a particular treatment strategy, and then putting the treatment strategy in place. Largely, the treatment strategy would include medicines like a mood stabilizer or something to calm you down as well, if you are in the hypomanic or a manic side. Cognitive behavior therapy might help, maybe not in the acute phase, but as gradually things recover. Psychoeducation, education of the family, requesting for accommodations at workplace or during their educational spaces would all include interventions for such a disorder.
Right. And is this a condition that can be lifelong?
I don't use the word lifelong for anything, but can it come back over and over again? Yes, it can. Right. So it can come back. If you're unlucky, it can come back every year, every 2 months, every 4 months. If you're lucky, then it might come once and might not ever come back again. But the rule is, if you've had the episode once, then it's good to be on treatment for a significant period of time so that the possibility of the disorder coming back is reduced.
Right. And just like in the case of depression, you discussed that there are social factors, psychological factors, and biochemical factors or biological factors. Is it true for this condition or these set of conditions as well?
True. As I said, all psychiatric disorders, these are the three categories of contributing factors for causation should be looked at. And all major psychiatric disorders, particularly major psychiatric disorders, tend to have a biological vulnerability. Science's ability to discover that vulnerability is limited at the moment. What we know is that medical treatment does help with all major psychiatric disorders and common psychiatric disorders.
Right.
And psychological treatment also does help. And social accommodations help people decrease the amount of disability that might come from such disorders.
Right. And the precipitating factors that you spoke about, I'm sure, during COVID or because of COVID, the cases of anxiety and even depression would have risen or at least being reported more. Is that true for mood disorders as well, or those two are unrelated?
Sure. No, life events, there's enough research on that. Life events like loss of spouse, change of house, loss of job, loss of money, even happy events could precipitate a mood disorder and do precipitate a mood disorder. But they have a predisposing and a precipitating component to that. They're not causative in nature, which means that they by themselves don't cause the problem. It is only together with the biological vulnerability that the problem is caused.
Right. And are there any other types of mood disorders as well?
One thing that people do normally come and ask about is seasonal affective disorder, a mood disorder that comes with the change of season. That happens more in countries where there is a decreased light during the winters. But it also, some people in India also see it. There are particular treatments for seasonal affective disorder, but largely what is required is a mood stabilizer.
Right. And what happens in this condition?
The depression or the high might come with the change of the season.
Right. And that's because of the amount of daylight or the intensity of the sunlight, or there are other factors?
Yes. Also? The biological rhythm within one's body of the light and day cycle the circadian rhythm, as it's called, gets uh, uh, disturbed because of the change of the light and day light cycles in our environment.
Right. And this would go away once the season changes as well?
It will require treatment. It might keep on coming back season after season after season.
Right, right. I'll move on to schizophrenia now in this last section. And some data suggests that 3 in 1,000 people may have schizophrenia in India. So, Dr. Bhagat, what is schizophrenia, first of all?
Right. So there are many myths about schizophrenia. One thing it's not a split personality.
Right. It's a very common thing to call it that, right?
Yeah. That's what literally the word means, but that's not what it is. Actually, schizophrenia could be seen as a group of disorders where there's a disturbance of behavior, thought, mood, perception, and also insight. One of the common features in schizophrenia is that a person might lose contact with reality and might start believing in things to be true when they do not exist or little evidence of them exists. So you could start having a prodromal phase where you withdraw from the world, where you keep to yourself. You have a sense that something's going wrong around you, but you don't know what it exactly is. You can't pinpoint it. Over a period of time, this might evolve to having delusions where you have false, fixed, firm beliefs about things around you. You might feel persecuted by people. You might think that people are talking about you. You might think that people are controlling your life. You might have perceptual difficulties, that you might hear voices commanding you. You might hear voices of people discussing about you. You might have visual hallucinations where you might see things which are not there. And it could be very, very disturbing. You might actually feel that people around you, there's a conspiracy around you. And given that you've experienced all this, you might start saying to yourself that you might start living in your own world, so to say, without realizing that all this may be a part of a disorder. So, and because you don't think of it as a disorder, you might not seek help because you might feel so afraid by your beliefs which have arisen because of the disorder, and you think of them to be true. You might not reach out and seek help, but people around you would be distressed, and people around you would keep on explaining to you the need to seek help, and that becomes the difficult point in this disorder. It needs to be treated early. If treated late, the disability is more, right? It could be precipitated with substance abuse. It could be precipitated by other life events, as we discussed. They could be these. What I described just now were the positive symptoms of schizophrenia. That means they're evident. There could be negative symptoms of schizophrenia, which could include lack of interest, asocialization, not being able to socialize too much, not being able to form friends, amotivation, not being able to motivate oneself to do anything, anhedonia, which means not being able to enjoy one's life, and a restricted affect, which means neither being too happy or too sad, being blunted in face of changes in one's life. There could also be what is called thought disorder. In the older times, it was called loosening of associations. So when we speak, words are connected and they form a sentence. And when sentences are connected, then they form a theme of what we say. So there could be a inter-sentence incoherence or an intra-sentence incoherence, that two sentences might not be connected to each other, or within one sentence, things might not make sense. These all could be called negative symptoms of schizophrenia. And they might come early or they might come late in the illness. Schizophrenia is an illness which causes the most disability amongst psychiatric disorders because the response to treatment, while good, has to be brought in early, and there have to be multiple ways of helping people remain connected to their community and not being blamed and incarcerated or abandoned because of their disorder.
One of our listeners, Varun, has put a question across to us, whose sister has schizophrenia.
Hi, I wanted to be anonymous. My sister suffers from paranoid schizophrenia for over 10 years. I had a question about whether this condition is more susceptible to a particular age group of people. Like when people do encounter the first symptoms or they're diagnosed, is there a particular age group and whether that varies across genders?
Again, cure is a difficult word. It is a magical word. Most non-communicable diseases do not have a cure, right? For hypertension, you do not have a cure. For diabetes, you do not have a cure. You have treatments, which means that if you take the treatment, the illness becomes better and the disability gets reduced and your quality of life increases. But somehow, when we use the word cure, it seems like we'll do something magically, things will go away, and the person will not have any restrictions whatsoever on their quality of life or on what they do in their life. That's not true. As of today, what we know is that people with schizophrenia can have a very good quality of life. The symptoms can be controlled. The treatment is necessary for a significant period of time. A number of people are able to, at some point of time, have a life without medicines, but which percentage, which patient will have, would be able to stop the treatment, would not be able to stop the treatment, is an individual decision that the patient and the doctor needs to make together with the family. It cannot be done theoretically. The guideline is that treatment needs to continue for a very long time.
Right. And what are these treatments that you refer to?
The treatments are, again, they are drugs that affect another kind of a neurotransmitter in the brain, largely dopamine, and also drugs that affect the serotonin metabolism in the brain. So those medicines are really helpful in controlling the symptoms. Our understanding of schizophrenia as an illness is an evolving process. People now say that over a period of time, if left untreated, there could be structural changes in the brain because of an illness like schizophrenia. So the important thing is for the treatment to be put in place. Apart from medicines, cognitive behavior therapy helps. It helps you cope with your symptoms differently. And it helps you put in perspective what the experience, the lived experience of the illness itself can be addressed, and the level of distress that you feel can be decreased with use of cognitive behavior therapy. Also, what is required is what I call inclusive rehabilitation. You need to, because schizophrenia may take you away from your education, schizophrenia may take you away from your work, you require a way of being included back into the domains of life that you've been included from. And that needs to be a gradual process, given the negative symptoms of schizophrenia of amotivation, asocialization, decreased concentration. It might require accommodations from the educational system and the work system to help you get back into work and education. Paranoid schizophrenia can happen in both all genders. It's important to recognize that, but the age when paranoid schizophrenia happens may be different for women, may be different for men. Other genders, the research is still evolving probably. Again, I would not worry about these distinctions. I keep on saying these are statistical facts that may help the policymaker. At an individual level, if you have the disorder, you have the disorder.
The second question is that what are the factors that typically lead to such a diagnosis? Is it related to just genes or there are other external factors like a trauma incident? I mean, are there any explanations that the medical science has come up with? Are there any 3 to 4 popular theories which could explain such a prognosis?
Remember the biological, psychological, social matrix of predisposing, precipitating, and causative factors, maintaining factors. So if you fill this matrix, then you realize that there's something in every square. There are biological predisposing factors, biological precipitating factors, and biological maintaining factors. Similarly, there are psychological predisposing, precipitating, and maintaining factors. Similarly, there are social predisposing, precipitating, and maintaining factors. Trying to tease out one cause for one illness is something that we would fail at. There's a genetic predisposition, there's a neurochemical predisposition. Some say there's a theory that says that there could be a viral infection. Some say there could be birth trauma that could be causing this. Some say that adverse childhood experiences might also contribute to it. There's no one factor that causes schizophrenia.
Right. And obviously, this requires specialist attention. So if somebody does have schizophrenia, do they need to go to a specific specialist? How should they approach the treatment?
Must meet a psychiatrist. Don't hold back. Don't wait for a crisis to happen. Don't wait. Schizophrenia has the most stigma in the society. This is where the assumptions of incapacity and dangerousness arise. This is where the concept of unsound mind arises. So not seeking help because of these stigmatizing factors is not helpful. Schizophrenia is a treatable illness where your quality of life can return. Emphasize on that to yourself and to the people around you. Don't be excluded from anything because of this disorder. Work together with your family or loved one on this one. Creating an oppositional dichotomy between yourself and the rest of the world, if you have this disorder, is not very helpful.
Right. And there are some, across the internet, or you do read a few cases of, unscientific, unproven approaches towards treatments. And these are, in other fields of medicine that, people may offer. What is your advice to people, who have schizophrenia or who have a loved one who has schizophrenia, to use or not use such alternative therapies, let's say?
I can tell you what helps, right? Yeah. And what doesn't help. You have then choices after that. What helps is early treatment with medicines and psychological treatment and being included back into your everyday life. That helps, right? The more you withdraw from everyday life, the later you seek treatment, and the more resistant that you are to medicines, or the more non-compliant that you are with medicines, the illness becomes more and more difficult to treat. That whether yoga helps, or wearing a blue color shirt helps, or watering the plant helps, I won't trivialize anything. Everybody's lived experience is different. My lived experience is that schizophrenia needs medicines and psychological treatment and return back to life.
Dr. Bhagat, thank you for taking time out to discuss mental health with us. It's always a pleasure to talk to you.
Thank you, Karan. Good to be there.
That was Dr. Achal Bhagat of Indraprastha Apollo Hospitals, who joined us for this episode of The Prescription. Do write to us for any information or any specific health subjects you would like us to cover in our future episodes. We're always happy to hear from you and to help. And do encourage your friends and family to download the Earshot app or subscribe to this podcast. Till the next episode, stay happy and healthy.
Earshot, here and now.